Welcome to Healthy Dose. Learn to repair damage, replace key hormones, and regenerate your body. Get ready to take back control and reclaim your life. Now's the time. Here's your Healthy Dose.
And welcome back to Healthy Dose. Dr. Joe and Dr. Buzz with you again. Today we're going to be talking about secrets to permanent weight loss. We've touched in the past quite a bit about intermittent fasting, caloric restriction, even looking at blood types to maximize weight loss. But today we're going to get into some of the specifics of blood work and some of the things that can cause hangups even when we are in a caloric deficit. You know, people that get stuck holding on to the weight and get frustrated and will abandon a plan. So I'm here with Dr. Buzz today. How you doing, Buzz?
Hey, what's going on?
So everything's good, Buzz. Really, I know you have in your office a true expert in the topic we're going to be speaking about today. This is, I don't know about you, I think there's pretty much two things that I get from weight loss patients that before they start a program, that they've tried diets before, they've lost the weight, they gain it back, or that they are dieting, they're in a caloric restriction, but they can't lose weight. And they always go back to thyroid. What if my thyroid is sluggish and my metabolism is slowed down? Even when I'm in a caloric deficit, I'm stuck. So it's a huge topic. There's not enough information out there. And so we're going to talk a bunch about that today. And I know you have quite a bit of experience with it with one of your lead doctors as well.
Yeah. I want to introduce, we're going to have with us today, Joe Matovich. Joe Matovich went to Otterbein University, has a degree in health and human performance, but most impressive is Joe has been in this space for about 12 years now and has literally treated thousands of people for hormonal deficiencies and thyroid issues. So I wanted to bring him on board because he has so much clinical experience and kind of pick his brain a little bit and talk about, in particular thyroid today, because as you've mentioned, Joe, a lot of people that suffer with, basically they, gain weight, and they're not eating that many calories and they don't have energy, and there's lots of other symptoms of thyroid issues, have these thyroid issues, and often thyroid issues, in my opinion, are treated improperly. So I definitely want to depend upon Joe a little bit and talk about, some of the ways that we treat thyroid differently in our offices.
Excellent. Hey, welcome, Joe.
Hey, how are you guys doing today? Thanks for having me on.
Yeah, great. Just to further on this topic, Joe, I think one of the things that we should speak about is a standard blood panel that is run traditionally in any type of office, to screen for, let's say, a metabolic panel, doesn't necessarily include all the information that we need to paint the picture of how healthy the thyroid may be or may not be. In fact, right, the standard protocol at the most would include a stimulating hormone, but not the actual hormones themselves or possible antibodies that can show up there if there's autoimmune disease present. So can you expand upon what specific tests that we're looking for on a blood panel to maximize weight loss if we're truly going to look at the health of the thyroid?
Absolutely. And when it comes to thyroid assessment, of course, the first part of an intake that I assist our doctors with is the subjective symptom profile. So that's the first thing we're looking at. From a lab standpoint, though, as you mentioned, the TSH, the thyroid stimulating hormone, is a very small piece of the puzzle. So one of the things that we always want to look at, or several of the things we want to look at in office to get a real picture of the thyroid, is not just the thyroid stimulating hormone, but also the metabolically active metabolites the thyroid's producing. T4, thyroxine, trithyronine, which is T3, the more metabolically active of the two. Specifically, the free or bioavailable versions of those hormones are what we want to look at. We do like to look at reverse T3, and then we're also going to look at autoimmune markers like the thyroid peroxidase antibody or the thyroid globulin antibody. That's what's going to rule out underlying autoimmune conditions like autoimmune thyroiditis, more specifically Hashimoto's disease. So, a TSH only may be a baseline indication to suggest if there's something problematic going on, but certainly doesn't paint the whole picture. And clinically speaking, if you're just tracking that, you're really working with limited resource and limited knowledge about whether or not the patient's being treated or managed appropriately.
So question, Joe, when you're only looking at TSH as many offices do to ascertain the health of the thyroid, what are some compounds that we can take into our diet naturally that can give you an elevated TSH that doesn't necessarily mean that you are clinically hypothyroid?
have an elevated TSH. So,
like for example, caffeine, monster drinks. Like, if you're consuming some of those before you have a blood test, maybe it pushes that number up a little bit, but that truly isn't your baseline.
No, yeah, you can see some little fluctuations like that with different supplements. Again, I haven't seen huge difference with that clinically. I see more impactful dietary issues when people are eating. Gluten intolerance, for example, is a big one that we see with people as far as TSH fluctuation and patient base, especially if they have an underlying autoimmune pathology. Thyroid conversion is selenocysteine and iodine dependent as well. So different deficiencies in selenium, iodine, or different supplements that may incorporate those can cause some baseline changes in TSH expression as well. But I would say the most impactful thing I see is dietary gluten consumption, especially in a patient that may have an underlying autoimmune disease process.
And what are some of the symptoms? We'll speak more about being hypothyroid, where you have difficulty losing weight. Some of the classic hallmark symptoms that you could see physically, is loss of the lateral third of the eyebrow. You can see some skin changes, difficulty, obviously, losing weight, and you'll see some other metabolic profile changes on the labs as well. But touch a little bit on physically, how will you feel when your body is just not able to convert or absorb some of these thyroid hormones?
So this is a conversation I have with our patients a lot, really to paint a picture of why the thyroid is so impactful. So, when we get to the root, pathology, what does the thyroid do for us? Specifically, what did T4 and more importantly, T3 do for us? And we know at a cellular level, T3 is most involved in mitochondrial health, function, replication, production. And as you guys both know, that is the organelle, the primary site in our cell for all oxidative or aerobic metabolism, most predominantly oxidative phosphorylation or fat breakdown. So if we have suboptimal production of or suboptimal response or output from the thyroid gland or poor response to it, in short, we're going to have metabolic dysfunction at virtually every cell in the body. So patients are going to present with a lot of symptoms that maybe initially they didn't correlate to one another, even though the pathology is the same. So the obvious ones, obviously, are the weight gain in the lateral thinning of the brow, but we're going to see this chronic abnormal fatigue. So how I describe this is things that people maybe did 5 or 10 years ago that weren't an issue, absolutely run them into the ground now. Although they may feel like they can sleep 12 or 16 hours a day, the sleep isn't restful. A lot of times they'll have insomnia symptoms, which seems counterintuitive. Thyroid's underactive, but they don't sleep well, even though they're chronically fatigued. Metabolic changes downstream, of course, you're going to see abnormalities in the lipid profile and sugar management, things like that. Dermatological changes, so thinning, dry, cracking hair, brittle or ridged nails, dry skin, changes in menstrual cycles for women, difficulty with bowel movement, specifically constipation. So there's a lot of downstream metabolic effects that we see in these patients, and it's because the thyroid is so prevalent at regulating so much metabolic activity down to a base cellular level.
Yeah, and Joe, I think something we've seen also clinically is these people will often even present with depression, and they'll go see their primary care, and they'll be on antidepressants, which don't help the whole situation. You're treating the wrong thing. I mean, it just contributes to this condition.
And that's a good point. And we see that in thyroid patients, similar to men with hypogonadism or female patients with early onset ovarian dysfunction, is they have this clinical symptom of what's called Anedonia, which, we kind of jokingly is the fancy doctor word for just a habitual case of the blahs. It's not an overt clinical depression, but it may present as depression if you don't dig a little bit deeper. And I don't feel motivated anymore. I don't enjoy the stuff I used to do. My previous leisure activities now feel like arduous tasks. I don't want to do them. I barely make it to the gym, and when I'm there, boy, my intensity really suffers. Instead of getting a good workout, I'm figuring out how I can get out the fastest and feel like I still accomplished something with my time there. If they used to like to go out and have a glass of wine and dinner on Friday nights, now when they get home from work, they want to find those gray sweatpants and sit on the couch and order pizza. So again, it does get misdiagnosed as depression a lot, when really we know the deeper rooted issue really lies under this endocrine pathology. So yeah, that's a very accurate statement, Buzz. For any of these hormone pathologies, really, we're going to see a lot of people presenting with depressive-esque symptoms, although it's not clinically depression in the sense that it's not really the neurochemical issue. So.
Yeah, and I think a lot of that goes too that it's misdiagnosed because the blood, the proper blood work isn't done. So, and Joe, we talk about that all the time. The blood work never lies, but if you're not doing the proper blood work, a lot of times they'll go to a primary care, and primary cares are great, but they don't specialize in this kind of stuff, and they'll do a regular blood work, and they'll just say, hey, you're getting older, or maybe a little bit of depression, and it's much easier to give an antidepressant pill than to treat, a hormone imbalance or a thyroid imbalance. That's something you really have to specialize in.
Yeah. So we're waiting for Joe to come back, Buzz, but I think one of the things that will bring Joe back on. Oh, there you
All
are.
right,
Joe.
sorry.
Yeah.
There we go.
No.
I don't know if my connection. Yep.
Yeah, we got you back. But Joe, we were going to talk about, the majority of people, when you look at this hormone profile, if you do have the basic 5 available to you, as you mentioned, the TSH, free T3, free T4, reverse T3, the thyroglobulin antibodies, I should say 6, and the peroxidase enzymes. What percentage would you say could be managed naturally by correcting, a leaky gut, by helping to reverse some insulin resistance and bringing the lipids under control versus actually having to go on some medication in your clinical experience?
So I would say we see it's far more prevalent in female patients than male patients, probably 4 to 5 more times. I think every patient needs to be managed on an individual basis. So it'd be hard for me to give you a percentage. I would say a lot of patients that are borderline, so maybe that TSH in the 3 to 6 range, a lot of times it can be managed with dietary correction and almost a functional medicine approach, if you will, which is correction of the insulin resistance, the underlying metabolic disease profile. Because as we all know, when we look at metabolic syndrome, that big umbrella diagnosis, if you will, all those subset diagnoses, whether it be prediabetes, diabetes, high cholesterol, hypertension, hypothyroidism, hypogonadism, they're all interdependent and perpetuate each other pretty dramatically. So we've seen pretty significant reduction in TSH, improved thyroid management, just with correction of maybe that underlying metabolic disease state, whether that be insulin resistance, correcting again, gluten is a big piece as far as thyroid management, and maybe adding some low dose supplementation, just over the counter things to help augment function. And we do see a pretty good response with that. So I don't think there's anything wrong with somebody who's borderline saying, hey, let's try these things first and see how you respond, and maybe track the thyroid again at 6, 8, 10 weeks. See if we brought the TSH down, see if we've improved T4 to T3 conversion, see how your symptoms are before we jump right into medication intervention, especially if there's no evidence of autoimmune pathology that's causing the issue in the first place.
Buzz, do you want to touch on that a little bit? Just as a follow-up to our leaky gut, when we were talking about some of these pathogens that escape through the gut and they make their way systemically through the body, and they do land on the thyroid. But by the time these antibodies show up, a good chunk of the thyroid could be damaged already, right? So it's very important to isolate and detect those things. Let's talk a little bit about Hashimoto's. It's not uncommon that people have heard of it, but I'd say the majority of our patients don't even know really what it is or that it affects the thyroid. So I know you have some experience with that, Buzz, and Joe, in your office. You treat quite a number of these patients, and you manage them very, very successfully.
Yeah, I mean, Joe, you've had more experience than I have, but Hashimoto's disease, the people that have thyroid, what percentage would you say actually have Hashimoto's?
I would bet that we probably see a 25 or 30% prevalency of Hashimoto's with thyroid patients. And I may be lowballing that even a little bit, but again, Hashimoto's, it's an autoimmune disease pathology. The body attacks the own thyroid, and that's why it's detectable with the antibody tests, the thyroid peroxidase and the thyroglobulin antibody. So that's often missed also, though. That's another one that's missed quite often. We've had a lot of people come in who have had diagnosed with hypothyroidism, maybe even being treated for hypothyroidism at the time. They never had an antibody panel run. And I mentioned, I'll ask them and say, well, is it hypothyroidism? Is it Hashimoto's? And they say, well, I've never even heard that word before. And we run an antibody test for transfer management. And of course, they come back positive. And again, when it comes to things like leaky gut, insulin resistance, dietary choices, when we get into autoimmune pathology like Hashimoto's, we know that the thyroid tends to be even a little bit more fickle and subject to fluctuation. So if you're not coupling the other modalities of management outside of medication, whether that be dietary adjustment, correcting the leaky gut, other disease processes, it makes the medication management an exponentially more difficult process. To give you an example, at the last office I was at, I had a patient with Hashimoto's disease. Of course, for HIPAA reasons, I won't name names. His TSH could be perfectly managed at between 0.5 and 1.5 when he was eating gluten-free and dieting appropriately. If he went out on the weekend and drank beer and ate a bunch of pizza, he could come in on a Monday. We could check the TSH, and it could be up to 35 or 40 with no changes in medication dose and perfect compliance with dosing. So when you're not checking those things and you're not determining the underlying pathology of the thyroid issue, I think it really gives you, shorthanded availability as far as correcting the thyroid from all avenues of treatment that are necessary.
Yeah, and we can actually assist with that too, just for the layperson there, basically what that autoimmune and the Hashimoto's is caused by is the leaky gut that Joe was just talking about. And that literally is basically food particles or proteins leaking out from the gut, and the body attacks it, and a lot of times it basically falsely attacks the thyroid gland. And, a lot of times people that have these autoimmune type conditions, we have a gut protocol we do in our office, Joe, I know you do also, that can help, patch up that leaky gut so less of these proteins literally leak into the blood system. The body attacks them so it doesn't recognize these are supposed to be in the gut, not in the bloodstream. So that's something that, obviously diet modification is number one, Joe, but for some people it's not realistic to never have a beer or a piece of pizza again. So we can supplement that by, giving them protocols to help fix that gut. And that's definitely something that's doable. And, even in my house, once a year, my whole family does the leaky gut protocol, even though, we eat pretty healthy. Because the gut over time breaks down with we're eating lots of processed foods and lots of different things. Getting that mucosal layer, thicker, restoring the proper flora to the gut is essential for health.
Yeah, even
absolutely.
I was going to mention too, Joe. Last week we spoke a bit about that Igg supplement too, which binds up to some of these pathogens even as they leak through the gut, so that they, they're not able to fit into the receptor site and do further damage, to the tissue. What I was gonna say, Joe, is that when we're talking about, let's just say for our patients that have hyperlipidemia, these triglycerides are elevated, and we speak about changing the diet, lowering saturated fat. I think a lot more people are familiar with foods that contain saturated fat. They're very familiar with gluten, but how many people actually know that gluten is a protein? And just to give an example of some of the foods that contain gluten, right? Even like condiments, like ketchup and mustard, it's in almost everything. So you really have to be conscientious and do some research on what is gluten in the foods that are prevalent in it to really get a handle on this as well.
Yeah, I agree. And it's one of those things where, as a patient, I think as a provider or a patient educator, we really have to make the patient understand that the most important advocate for their health and well-being is themselves. And if it's something that they want to correct and it's very important to them, there's going to be a little legwork on the back end for them. We can give them the resources and tools as well. But the internet's a tremendous tool. It gives you research and accessibility at a level that most people probably 20 years ago never imagined we would have. And you're right, gluten, again, it's a structural protein primarily in wheat products, but when you look at the prevalency in other food-based products that you would never even consider, even some products that are labeled gluten-free aren't truly gluten-free. They just have a minimum threshold required by the FDA to be called gluten-free, but may still contain some traces of gluten in it as well. So, that dependent level of gluten sensitivity is going to vary person to person. But for a patient who has a really pronounced issue, they're going to have to do a little bit more digging as well to make sure that they're really eliminating it from their diet. So
let's dig down a little bit now on the healthy person. So there's this secretion, this thyroid stimulating hormone. It causes the body to release some of these hormones like the T4, the conversion into T3, mostly in the liver. And then the body with that signaling hormone is able to control metabolism. It aids in weight loss, control of temperature, thermogenesis as well. Let's touch a little bit on reverse T3, Joe. Like that's another one that even if you do catch the TSH, the free T3, free T4, and the antibodies, that can set you off to where you could be less optimal in terms of your goals if you have an excessive amount of this reverse T3 in terms of blocking some of the receptor sites for actually the body absorbing T3. Can you touch on that a little bit for us?
Yeah, exactly. So for simplistic terms, it's essentially measuring the portion of the T3 that's going to be metabolically unavailable to the tissue, if you will, or isn't making it to receptor sites. So when you look at availability and uptake as far as those hormones, T4 more abundantly produced, T3 the most metabolically active of the two by far in terms of hypermetabolic capability and mitochondrial function. So, when we look at reduced receptor uptake, reduced availability of that T3, this is when we're getting to the finite management of thyroid. Somebody who maybe has a great TSH and adequate T4, maybe a low to moderate T3, but poor T3 uptake, may still present with clinical symptom profile and have the downstream metabolic effects. So that's, and that goes back hand in hand with, as you mentioned, why all of these lab parameters are so important to check to really assess and treat the thyroid adequately.
And do you have any keys on what to do? Like if you have, it's almost like that sex hormone binding globulin. When you see that too high, it's going to interfere with the body's ability to collect free testosterone. If it's too low, it's an indicator of insulin resistance. What are some of the things available to us to modify the uptake of that reverse T3? Is it, again, controlling diet? Is it correcting the leaky gut? Is it trying to reverse some of that insulin resistance?
So any metabolic, and again, as you mentioned, a lot of this conversion process, a lot of the uptake process is dictated by hepatic function and liver. So when it looks at T3 uptake, that's a little bit harder one to argue. As just with the sex hormone binding globulin, there's thyroxine binding globulin. There's some things to evidence that even sex hormone binding globulin may have binding potential to the thyroid hormones as well. And again, those are primarily induced via the liver itself. So anything that adversely affects the liver, whether that be insulin resistance, whether that be leaky gut, whether that be hepatic, steatosis, hepatic steatosis, the fatty liver disease, all of those things could impact that as well. As far as downstream effects, as far as receptor sensitivity or uptake, there's not anything I'm familiar with that actually agonizes the thyroid receptors itself. But as far as the availability of the T3, certainly anything like binding protein production via the liver is going to affect the T3 just like the testosterone will, or just as it will affect testosterone.
So Buzz, just like, when we speak about patients that have primary hypogonadism, there's only so far the body can go on its own, right? Eventually we're going to make less of these essential hormones that we need to maintain our health than we had when we were younger. And it's affected by a multitude of factors from external stresses, epigenetics, and so forth. So let's just say patient is not able to adequately convert T4 into T3, or just the uptake isn't there. Now let's talk about intervention versus, synthetic intervention or traditional medical approach versus some of the, bioidentical approaches using maybe Armour thyroid or natural thyroid, W thyroid. Can we touch on that a little bit?
Yeah, absolutely. So, sorry, I don't know if you're reckoning that to me or Buzz. There's low level intervention. So let's say you have, for example, somebody who has appropriate thyroid function, if you will. Their TSH looks good. They have adequate T4 production, but they don't convert well to T3. If you have a patient who's a little hesitant to get on medication just for the T3, we know that those diagnose enzymes, D1, D2, D3, are seleniocystine and iodine dependent. So sometimes it's as simple as supplementing with an over-the-counter selenium to aid that conversion process. If it starts to be a production issue, a lot of standard medicine for treating thyroid is the use of things like levothyroxine or Synthroid would be generally the brand name. Where those can fall short with patients at time, though, is levothyroxine, Synthroid are a synthetic T4 only medication. So say, for example, we have a patient who does have hypothyroidism, but they lack the capability to adequately convert T4 to T3. We may get their T4 to an adequate threshold. We may get their T3 to an adequate threshold. But if they do not convert to they may get their TSH to an adequate threshold, get their T4 to a good level. If they don't convert to T3 well, the relative metabolic benefit is going to be minimized, and their response to treatment from a subjective standpoint is going to be very lackluster as well, because the T3 is so more metabolically active. Sorry, it looks like my camera cut out on you guys there. Yeah. So
we still got
you still got me?
Yeah, we still hear
you. So when we look at assessment as far as treatment goes on a per patient basis, there's a couple different routes that you can go. So if you treat somebody with a T4 only medication, they don't convert well. TSH, T4 may look good on paper. T3, if that doesn't come up, their response to therapy is going to be a pretty blunted or suboptimal response. Now T3 or the Synthroid in a lot of practices still standard of care, if you will. What we tend to defer to in our office, especially for patients who don't convert well, is a porcine, a pig-based desiccated thyroid. It's a more naturally occurring thyroid medication. The benefit to that is that it also contains T3 in it. So it's a T4 and T3 supplementation rather than T4 only. So for those patients who don't convert to T3 well, we're giving them an exogenous dose of it to help support both thyroid pathways. As far as traditional medicine, most primary cares don't supplement T3 prevalently anyway, but if they do, kind of the go-to option is adding another medication called Cytomel or liothyronine to Armour Thyroid, which, not saying it doesn't work, but it's a difficult medication to dose with patients because just like the thyroid medication, it needs to be taken on an empty stomach, and it's an extremely short-acting drug. So it can be needed to dose 2 to 3 times a day for adequate T3 levels, and it has to be taken on an empty stomach. So you look at most patients, do they have the time 2 to 3 times a day to not eat for an hour before or 2 hours after a medication to supplement T3 directly? So I find that most patients, and as you guys know in practice, the compliance of a patient with dosing frequency goes down dramatically when we look at 1, 2, 3 times a day. So for the patient who doesn't convert well, who needs T4 and T3, I personally feel that the things like the Armour Thyroid, the MP Thyroid, are not only more convenient for the patient, but clinically more effective. And then you have the argument that you're using a desiccated, natural occurring thyroid hormone instead of a synthetically derived hormone that's going to resemble or mimic, those hormones of the body.
Yeah, Buzz, and I remember back from your old bodybuilding days, right? So some of the competitors at the end stages of the prep would use something called Cytomel, which is really active T3, if I'm not mistaken. So and the reason they would take it is to really drastically lose body fat, and it's so strong in terms of overstimulation or overabsorption of that T3 that it could actually cause you to lose some muscle. But taking a step back, when you adequately absorb T3, a lot of the weight loss goals that you may be struggling with can be met.
Yeah, and that's why I think any weight loss program, you really have to not only look at the diet, but and I think Joe would agree. You got to look at the hormone panel, and you got to look at the thyroid panel, and an in-depth look, because so many people that suffer with obesity, it's not only what they're eating, it's their endocrine system, their hormones, their testosterone, their estrogen, their thyroid levels are just messed up. And these people are literally starving themselves to death, and they're exercising, they can't lose weight. And they become disheartened about it when it's really just an endocrine problem that we can treat with bioidenticals and get great results.
Yep. Joe, question for you from the patient. Sorry, Buzz. Go ahead and finish.
That's why every weight loss program, I think in your office is the same way. Everyone gets a full blood panel that does weight loss just to make sure we're not missing something, because it doesn't matter what you do diet-wise. If you have endocrine issues, you're not going to be happy with the results.
Yep. And question that I could tell you, Buzz and Joe, that we get a lot in the office, patients that, when they're going to be starting any type of a program, even the bioidentical HRT, is, am I going to have to take this forever? Will my body become strong enough to start producing more testosterone as I age and become more stressed? Is that going to reverse itself? Same question we get with thyroid. If someone has to go on some of the meds because of poor function, poor absorption, is there any type of self-regulation or self-healing that can occur over time where they'll become less reliant on the meds?
With the thyroid, and I'm just telling you this from 10 years clinical experience, as we mentioned before, there's some dietary modification you can make. There's correction of the leaky gut, correction of the underlying metabolic disease profile, and those can all help. But when we generally, when we see the development of a true endocrine pathology when it comes to thyroid dysfunction, a lot of times it is something that's a lifetime issue. We know with autoimmune thyroid pathologies as well, there's things you can do to help control that autoimmune process. But we know there's an increased propensity for total thyroid failure annually with Hashimoto's disease. So it depends on the level of dysfunction of the thyroid. It depends on what the root cause is. But once we get somebody onto medication, generally speaking, it's something that they're going to be on long term.
We talked about that, Buzz, just as it related to medical weight loss, the hang up of doing something that's, this is not something in terms of medical weight loss that you will do to maintain a healthy weight loss, but in some of the products that you take, I would suggest would not be as healthy to take or continue, right? Like, for example, if you're going to take Adipex to boost the metabolism, to lose some fat in hard to reach areas, you're not going to take that forever. But I would argue the fact that to do something in the short term, to take 30, 40 pounds off, to maybe, as Joe said, reverse some of these changes and control it without medication, I think that the benefit far outweighs the risk of waiting to do this by yourself or just being afraid to do some of these labs, because the damages from obesity or hidden autoimmune condition, like you said, Joe, could result in total thyroid failure. And so that's a note to the patients out there that are listening is do the labs. Don't wonder if you have this. It's very, very important to get the diagnosis or the diagnostics. More information is always better. The more information your provider has, the more they're going to be able to help you.
Yeah, and that's a big talking point I have with a lot of our weight loss patients is Dr. Joe, I know you do. We're not going to put you on a weight loss program without pulling blood work first. Because if you're not looking at the lab profile, you could be putting a Band-Aid on a knife wound. Yeah, you're right. We can push you in a caloric deficit. We can put you on things like Adipex, and that will pull weight off. But there's two things we don't want to have happen. We don't want to get 90 days down the road. We've done these maybe more intense interventions that are short-term use only drugs like phentermine, and one, not seeing the response that we not achieved our goal, or two, assist you in losing this weight, and then as soon as you come off of that and you go to a more stable caloric intake, have a massive rebound in weight. So tracking that blood on the front end, I mean, if somebody has hypogonadism, if they have low testosterone, if they have hypothyroidism, we know that the downstream metabolic effects of those hormones is so pivotal for maintenance of not only a healthy weight, but appropriate metabolic function. We don't want to get 90 days down the road and not have the success we want and say, oh, well, shoot, we should have done something about this in the first week we were doing this. Or have you come back in 6 months and say, oh, well, I gained all this weight back, and then say, oh, well, maybe we need to look at what's going on with your hormones now since you didn't keep it off. One of the things we always tell our weight loss patients is we love all of our weight loss patients, but we don't want to have to keep seeing them, because then we feel like on our end, we failed them as a provider. If we have to have somebody back every 3 to 6 months to repeat a program, well, then there's probably a piece of the picture that you're missing. And I would argue that the hormonal component is probably the biggest piece in the aging and the weight management and metabolic process. So it's not just about getting the weight off. It's also collecting all the information you need to make sure the patient's successful and arming them with all the tools absolutely necessary to make sure that what they're doing is healthy, effective, sustainable, and bodes well for long-term metabolic and endocrine health.
You could speak to that, Buzz, because, just because we get your thyroid balance with the correct medication supplementation, correcting leaky gut, doesn't automatically mean you're going to lose weight. It's just like going into the gym doesn't mean that the weights are going to automatically lift themselves and you're going to become conditioned. There is a good deal of self-discipline, perseverance, commitment that comes with any type of lifestyle change. Buzz, we've known each other, I mean, it's got to be 25 plus years now, and I can't ever recall a time when you were out of shape. And this is part of a lifestyle, and if we're going to talk about longevity, I can't think of anybody better than you in terms of diet, the way that you work out. And you could touch a little bit about that, like what should a person expect if they want to maintain a healthy lifestyle, whether it be good body composition or a healthy weight?
Yeah, I think everyone has to exercise, and exercise doesn't necessarily mean going to the gym and lifting weights, but get outside, go for a walk. The body's meant to move, so even if it's just a half hour a day, go walk for a bike ride or go for a walk, you have to move. It's good for your metabolism, it's good for your blood flow. It's a must. I personally like weight training and resistance training because not only the more muscle you have, the faster your metabolism is, but it also does a lot to help strengthen your joints and strengthen your bones, especially as you age. That doesn't mean you have to join like a hardcore powerlifting gym, but any type of resistance training is going to be a benefit for that. And then pretty much we are what we eat. So if you're taking a bunch of junk in, if you're eating fast food and sodas and all that kind of stuff all the time, you're just not going to feel good. So it doesn't mean you have to eat clean all the time. Everyone, there's cheat meals here and there, but the fresher the stuff you put in, good, lean proteins, chicken, fish, fruits, vegetables. You really want to focus on those things and try to, minimize the refined carbohydrates, the pizzas, the pastas, and those type of things, And most people kind of know this innately anyways. And another thing I'm a huge fan of, and I know you both of you are also, is doing some intermittent fasting, because I think, just not eating is really good for the body. And with a lot of times you mentioned fasting, someone's first reaction, oh my God, I'm going to starve to death. It's going to be terrible. Not eating 16 hours a day, a couple days a week is really easy. And I think, and that includes your sleep. So basically, if you quit eating at 8 o'clock at night, you can eat the next day at noon. The days I don't eat, I actually feel better. You'll find that after you eat you have your donut and a cup of coffee in the morning, you might feel great for a half hour, and then you crash. The days you don't eat, you actually have more energy. And fasting is really the easiest diet, in my opinion. Is this healthy? Is that healthy? You don't have to worry about that. Just don't eat. And not only is that really good for your metabolism, it's really good for your gut health and lots of other things. And there's more and more research on that. So, I'm not trying to overcomplicate things, but if people would ask you what are some of the key things, I think intermittent fasting, 16 hours a day, at least 2 days a week, and just remember, when you're putting something in your body, we all kind of know, is this junk or is it good? If it's junk, just realize that's okay here and there, but definitely not every meal.
And here's the good news: is that, to your point, Buzz, is that the dietary corrections that you make yield very positive results. The same dietary changes that could potentially help improve the the thyroid absorption or the stimulating hormone, or the exact same dietary modifications that can help with control insulin resistance, which are the exact same dietary modifications that can help heal and correct a leaky gut. So we're not talking about three completely separate diets. A lot of these changes, they're one change that have a platitude of different health benefits. Joe, is there anything else that you wanted to touch on that we're missing out on, like any of the key points of the thyroid? I will say this: you did mention, I think people get into trouble when they take blood pressure medication, when they take thyroid, whether they're taking it with or without food, maybe not giving themselves enough time after. I think that's a good point to maybe touch or close with, is what's the best time to take thyroid medication if you're taking it once a day, twice a day, for maximal benefit?
So the thyroid medication dosing, generally standard, is first thing in the morning, right when you wake up, and you want nothing else in the gut. I'm sorry, I dropped my picture again. Nothing else for 45 minutes to an hour. That's really ideal. Not to say that anything deleterious to your health is necessarily going to happen if you accidentally one day eat with it, but it does reduce absorption, uptake, and delivery of the medication pretty aggressively if you eat with it. So first thing in the morning, empty stomach, just with water for 45 to 60 minutes. That's where people are going to get the best absorption of the thyroid medication, is in a fasting state, if you will.
Excellent. And anything in closing, Buzz, that you wanted to touch on?
I think the main thing for people listening here today, and you're wondering if you have a thyroid type condition or you're getting treated for thyroid, make sure you get a complete blood work done, not just a standard thyroid panel, but an expanded thyroid panel. And if you're struggling with diet and you feel like you're exercising and not eating properly, once again, get that blood work done. We find so many people that have these weight loss issues and just feeling terrible issues, or even people that have been diagnosed with depression. Probably, I don't want to speculate on the percentages. Depression is real, but a lot of people suffer with depression. Do they really have depression, or is it some type of thyroid or hormonal imbalance?
Yeah.
So the blood work doesn't lie.
So click the link below. Joe's contact information is there. If you have a blood panel that you'd like him to review, if you're in the the greater Midwest area, I know you manage a lot of people across state lines, Dr. Joe, Dr. Buzz. Yep. You'll be able to use them, and he's a phenomenal resource on any of your healthcare needs, and in addition, your endocrine needs, whether it be bioidentical hormone replacement, management of the thyroid, or medical weight loss. We're down here in Miami. You can get all of our contact information below. Hit the like, subscribe button. Dr. Joe, Dr. Buzz, we'll catch you next time with the Healthy Dose.
All right, great. Thank you, gentlemen.
Bye.
Look at it.
Thank you for joining us. This has been your Healthy Dose. If you enjoyed today's show, hit that like and subscribe button before you go. We appreciate your support. For more information, recaps on previous episodes, and to find out what's next, follow us on Instagram at Healthy Dose Show. Remember, repair, replace, and regenerate. See you next time.